Good morning. This lecture is on Introduction to Residual Ridge Resorption. We all know that residual ridge is the portion of the residual bone and its soft tissue covering that remains after the removal of teeth. When you looked in these pictures, what are the changes are taken place in the dentulous to edentulous mandible? So it is a RR is the term used for the diminishing quantity and quality of the residual ridge after teeth were are extracted. We have a very important hard tissues, bone and teeth. Bone is a modified connective tissue which consists of bone cells and intercellular substances. The bone cells mainly consist of osteocytes, osteoblasts, and osteoclast cells. Also, more of osteoprogenital cells belonging to periosteum, blood vessels, nerves, etc. And the intercellular substances are composed of glycosaminoglycans and proteoglycans. Mainly two glycoproteins, osteonectin, osteocalcins are more in the intercellular matrix, and it also consists of organic and inorganic cells. So the inorganic ion mainly consists of calcium and phosphate in the form of hydroxyapatite. Apart from this calcium and phosphate, there will be magnesium, carbonate, hydroxyl, chloride, fluoride, citrate, sodium, and potassium ions are also present. RRR, it's a chronic, progressive, irreversible, and cumulative disease process, probably of multifactorial origin. Let's see the pathology for RRR. This pathology is divided into gross pathology and microscopic pathology. Let's see the gross pathology. When you look at in the structure of the residual bone, there will be a change in the residual ridge height and also the size of the bony ridge under the mucoperiosteum, which is primarily localized. Under clinical examination, we can visualize the residual ridge form. However, this may be masked with a reddened or inflamed soft tissue. So it can be determined by palpation method. There are the other methods to study the pathological changes in the residual ridge will be models, comparators, gross anatomy like position of the Mendel foramen and inferior alveolar canal, histology when we have to section the bone, examine under microscope, you can see more of osteoclast, then OPG in different stages, lateral sephogram, microradiography, other techniques we can see using with radioactive materials. Dove class Allen classified the residual ridge into 6 orders. Order 1 is pre-extraction. In the pre-extraction stage, there will be a buccal plate, lingual plate supporting the natural tooth. The post-extraction, the tooth will be removed. Then the remaining buccal plate and lingual plate will be remaining. In order 3, there will be organization of the blood cord which leads to formation of the crustal bone which will be well-rounded. In order 4, because of the resorption taken place buccal as well lingual aspect, the residual ridge become knife edge. When you, as the years goes, the resorption again continues, leads to low well-rounded, then it leads to depressed type of residual ridge which is order 6. In the pre-extraction stage, you can very well appreciate picture that how the teeth are supported by mucosa and residual bone. In this picture, all the teeth are extracted and you can see the buccal and lingual cortical plate with the inflamed mucosa. After some time, the that is callus formation organization leads to high well-rounded residual ridge. Because of the resorption, the ridge become knife edge in shape. Then as it continues, the ridge become low well-rounded. Then it becomes depressed in the geriatric patients. Another person, he classified the residual ridge into 3 type of defect. Class 1 defect, loss of faciolingual width with normal residual ridge height. Class 2, loss of residual ridge height with normal residual ridge width. Class 3 defect, combination of loss of residual ridge width as well as height. So let's see the microscopic pathology of triple R. So like microscopic pathology means we have to section the bone and examine under microscope. We can see more of periosteal bone and the lingual and inferior border, but with little bone on the labial surface. There won't be any bone on the crest of the residual ridge. Also, we can see more of external resorption, which leads to widening of the mandible and narrowing of the maxilla. Because of the internal remodeling, the ridge gets very narrow labiolingually and the cortical plates don't necessarily disappear. And more evidence of osteoporosis, increased number of closed osteons and increased number of endosteal porosity, increased number of plaque also leads to microfractures. So also the mucoperiosteum shows varying degrees of keratinization, acanthosis, edema. Also, we can see varying inflammatory cells in both in the denture and non-denture areas of residual ridge cases, subcases. For further details, you can refer the following textbooks for residual ridge resorption. Thank you.